Greetings and a warm welcome to all the PhysioTV viewers. I am Dr. Farheen Patel, Assistant Professor at Sancheti College of Physiotherapy. Today, we are going to learn about PCOS and its treatment, both medical and related to physiotherapy. This talk is going to be divided into two parts. In the first part, we will try and cover the reasons about PCOS and PCOS in general with the medical treatment. And in the second part, we'll try to cover the physiotherapy treatment. With that being said, let's start with the talk. So a few fun facts about PCOS. Did you know that the prevalence of PCOS in India ranges from 3.7 to 22.5%, which means that out of 10 women in childbearing age, one is affected by PCOS. This being a very prevalent and common disorder, but very underdiagnosed in adolescents. If this is caught early in the adolescent period, the later on phases can be managed easily. Hence, the importance of today's topic. Let's understand the difference between the normal menstrual cycle versus how it is disrupted in PCOS. So we know that in regular menstrual cycle, 4 hormones are very important, that are LH, FSH, estrogen, and progesterone. Now, all these hormones are controlled by the higher center in pituitary. And whenever we have normal menstrual cycle, there is an increase in FSH, which stimulates the follicle development, and LH, which stimulates the ovulation. That is, it stimulates our ovaries to lay down eggs that are ovums. And the fluctuations of this FSH and LH help to regulate the production and release of estrogen, progesterone, which will be high throughout our menstrual cycle. Now, what happens to these hormones if we have PCOS? So there is the higher LH does not allow for normal follicle development. So initially, like you can see in the first picture, the FSH and LH are on the lower end. But if you have PCOS, the LH is on the higher end. So it does not let FSH do its work and stimulate follicle development. Because of this, FSH is not increasing, leading to the high surge that we see on the day of 12 to 14 of LH. That does not occur because FSH is not increasing. The sudden surge of LH will not happen, leading to non-stimulation of ovulation. So this means that because LH's surge is not there, this surge which we see in normal menstrual cycle is not there, leading to non-ovulation. This will lead to the ovaries not releasing the ovum to the uterus. So this leads to no natural fluctuations in LH and FSH, which will then not be able to regulate the estrogen or progesterone. And higher LH stimulation, this steep continuous plateau of LH is gonna stimulate androgen production, and then androgens are gonna aromatize the estrogens, and this is gonna lead to androgen dominance, leading to signs and symptoms of PCOS. So the higher the androgen level than the estrogen and progesterone level, and then this is going to cause no menses. So which is why it is commonly seen in patients with PCOS that they have irregular menstrual cycle. They don't have it each month. So this was about PCOS. Disturbances related to menstrual cycle. Then we'll go ahead with what is PCOS. So PCOS, or polycystic ovarian syndrome, is a hormonal imbalance caused by the ovaries creating excess androgen, like we saw just now. Then females with PCOS often have erratic menstrual cycles, missed periods, and unpredictable ovulation. Now, a lot of times we get confused in what is PCOS and what is PCOD. Are they both the same or are they different? If they are different, how are they different? So PCOS and PCOD, we'll first look into PCOD. So PCOD, or polycystic ovarian disease, is a condition in which the ovaries produce many immature or partially mature eggs, that is ovum. This happens due to poor lifestyle, obesity, stress, or hormonal imbalances. Its clinical features are that it has irregular ovulation. It is commonly seen in obesity, or it can lead to obesity, alopecia or male patterns in baldness, then irregular periods and difficulty in conception, though it is not as difficult in PCOD as it is in PCOS. Also in PCOD, there are minimum number of cysts seen in the uterus or the ovaries. It is more of a metabolic disorder than endocrine, and the genetics or insulin resistance, inflammation, or weight have an effect in PCOD. If you follow a proper diet, exercise regularly, then it can be controlled immediately. And it is not so difficult in conception or conceiving. Also, there is a term known as PCO, which is only polycystic ovaries. It is not it does not correlate with PCOD. So PCO is basically due to a variant of normal ovaries, and ovaries with high density and partial immature follicles are here. It can be easily diagnosed with ultrasound. It does not show any signs and symptoms, but it can be associated with PCOD, but it does not associate with PCOS. And it is usually diagnosed in the later stages of life and not in adolescent. Here, the patients will regularly ovulate, but the menses are not that regular. Whereas in PCOS, it is a metabolic and endocrine disease and more severe form of PCOD, and can lead to anovulation, where ovaries stop releasing the eggs altogether. Like we saw in the first slide, that if there is no LH surge, all the other hormones will get affected, leading to the ovaries not releasing the eggs, which is anovulation. So it is related again to hormones and is independent of PCO. Here, the hormone levels of estrogen are low, but androgen are high. Hence, it can give us signs and symptoms like excessive hair growth, acne, risk of difficulty in conception, and cardiovascular diseases. PCOS is also very prominently researched to be in correlation with insulin resistance. So patient have with PCOS will show you a lot of hormonal imbalances and will have difficulty in conceiving. It is also seen that in PCOS, it is rare and seen in less patients as compared to PCOD, but it is prevalent. So if you are on the obese side, or if you have a family history, then you should always get checked in the adolescent period only. Then let's talk about the clinical features of PCOS. Here, there is enlarged and bulky ovaries with more than 10 ml of volume, leading to overproduction of androgens. More than 12 follicles, each measuring 2 to 9 millimeters in diameter and organized around the lining of the ovaries like a necklace. So this can be seen under an ultrasound. Then the symptoms that the patient will come with is irregular menses or missing of periods for almost 2 to 3 months. Then if the periods do come, then there will be a heavy flow and acne, hair loss, especially in the pattern of the male baldness, because the androgen is predominant in such females. Then android type of obesity is commonly seen. Android or apple-shaped obesity means where the accumulation of fat is more in centrally. In females, we usually see gynoid type of obesity where the accumulation is on the buttocks and the thighs, but females with PCOS will come more with central obesity. Then infertility, insulin resistance. Insulin resistance is a tricky thing. It can be leading to PCOS, or PCOS can be leading to insulin resistance. So it is kind of cycle, which we'll see further. Then such females will have more chances of gestational diabetes, excess body weight, that is again correlating with obesity, hirsutism, which is excessive hair growth on various parts of the body, because of course androgen is on the higher side. Now the causes of PCOS are hormonal imbalance or genes. Now in hormonal imbalance, raised testosterone, which is an androgen, raised levels of luteinizing hormone. We usually know that pituitary, whenever we enter our menstrual cycle, will release FSH and LH, which will lead to the surge of FSH and LH, which will get attached to the granulosa cells and theca cells in the ovaries respectively. Like FSH gets attached to granulosa cells and LH gets attached to the theca cells in the ovaries, and this theca cells will stimulate the androgen release. Now if there is insulin in the body, it again stimulates androgen production in the ovaries. So the insulin will act on the ovaries, on the get attached to the theca cells, and will want more production of androgens. And then androgen, of course, gets again released to gets converted into estrogen. And this is the cycle. But if there is a constant raise in LH, that is luteinizing hormone, it will constantly stimulate the theca cells to release androgens. Likewise, when there is an insulin resistance in the body, which means that the body tissues are resistant to the insulin, this will also stimulate the release of androgens through the ovaries. And though genetic part of PCOS has not been well researched and studied, it has been seen that there is a strong correlation of PCOS if you have a family history. So if anyone on your mother's, like the mother or your grandmother had a history of PCOS, there are high risk of you also having PCOS. Let's talk about this resistance to insulin as a cause. So high levels of insulin causes the ovaries to produce testosterone, which is an androgen. This interferes with the development of the follicles and prevents the normal ovulation. So as long as there is high level of androgen, the ovaries will not be able to release the ovum. Hence, the formation of follicles due to high LH and low FSH will be there. This hampers the ovaries function, that rises the androgen levels, which leads to anovulation, which we saw that is when the ovum is not released from the ovaries. If the ovum is not released from the ovaries, there will be fluctuation in your menstrual cycle. Then how do we diagnose PCOS? There was an evolution of this diagnostic criteria for PCOS. Initially in 1990s, it was thought that if you have hirsutism, if you have irregular menstrual cycles, and if you are and if you have hyperandrogenemia, then it will be labeled as PCOS. They only had one criteria, saying that the other causes of hyperandrogenemia should be ruled out for it to be seen as PCOS. Then later on, it was restudied, and the current diagnostic criteria is given by Androgen Access Society, which states that ovulatory and menstrual dysfunction, hyperandrogenemia, clinical features of hyperandrogenemia, and polycystic ovaries should be seen in ultrasound. Only then it will be categorized under PCOS. They have kept the criteria of finding out whether there are any other causes of having hyperandrogenemia, and if there are no other causes found, only then it should be labeled as PCOS. If they find any other cause leading to hyperandrogenemia, then they will pertain that irregularity in the menses to that root cause which is leading to the hyperandrogenemia, and they will not label it as PCOS. So this is the recent most diagnostic criteria for PCOS, which is being currently followed. Of course, you will also have to look into the other signs and symptoms that the female comes in, like if not only irregular menses, but whenever the menses come, is there heavy flow? You have to look into the ultrasound, how many cysts are being seen, and then differentiate between PCOD and PCOS. Like we have seen in our initial slides, you have to differentiate between PCOD and PCOS also. Then we'll come to the last topic for today's talk, for the part 1, that is the medical treatment. Now, medicine people have divided the treatment in 2 parts, that is control of irregular menses and treatment of hirsutism or hyperandrogenism. So for irregular menses or control of irregular menses, the primary treatment that will be given is in the form of oral contraceptives or metformin. Then there can be periodic progesterone withdrawals and lifestyle modification as well as weight loss. Then for treatment of hirsutism, they give the treatment in the line of decreasing testosterone production, decreasing the testosterone action, oral contraceptives, and again lifestyle modifications and weight loss. A lot of times it is questioned that what a physiotherapist can do in such conditions which are more related to the hormones and less to any other impairments. So this part of lifestyle modification and weight loss is where we come into picture. Now this weight loss and lifestyle modification, how this can be done, how we can go ahead with the exercise protocol in such females to reduce their irregularity in menses, and as well as how this exercises can lead to protection from the imbalance of hormone, we'll see in our next part of the same talk. In medical treatment as well as physiotherapy treatment, it is very important for us to educate the female properly, whether she has a PCOD or whether she has PCOS. It is important for us to let the female know what are the signs and symptoms that she can face, how it can be treated, and how it is not a threat to her, but on the same time how these lifestyle modifications, the changes, the small changes in her habit and regular lifestyle can lead to bigger changes later on. So we'll stop here for our part 1. Hope to meet you all in the part 2 of PCOS and physiotherapy. I would take this opportunity to thank our chairperson, Dr. Sancheti. I would like to thank our executive director, Mrs. Manisha Sangvi ma'am, for their continuous support and motivation. I would also like to thank Dr. Apurva sir, our principal, to give us such opportunities and such a good platform to share the information to all of you. I would also like to thank the PhysioTV team, the technical team, for organizing and helping us out for the technical part. Thank you all, and of course the viewers for continuous support that they give us. Thank you and have a nice day.